Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
I'm Angel Desai. I'm the Fishbein Fellow for JAMA.
Great, so welcome back, Angel.
Thanks for having me.
Great. So our first paper we're going to talk about is the effect of sequential or active choice for colorectal cancer screening outreach, a randomized clinical trial. And we've got first author, Dr. Siobhan Mehta with us. Welcome.
Thank you for having me.
Great. So why don't you tell us a little bit about yourself, what you did here in the study?
Sure. My name is Siobhan. I'm a gastroenterology physician here at the University of Pennsylvania. I also lead a lot of innovation efforts focused on developing, testing, and scaling new ways of delivering care across our health system. So I'm the Associate Chief Innovation Officer. And in our study, we basically were trying to tackle something that's really important for me as a clinician, which is trying to increase colorectal cancer screening rates. So we know that colon cancer is the second leading cause of cancer death in this country. Yeah, and there's actually really effective ways of screening and preventing early stages of cancer. Yet for a variety of reasons, only about 2/3 of the country participates. And we're fortunate to have a lot of different options. And so some of the things that we tried to address with this particular study was to think about how we can do outreach. So how we can reach out to patients when they're not seeing us in the clinic to encourage them to get screened, and also how to offer different choices between different tests. So there's actually 5 tests that are recommended by the U.S. Preventive Services Task Force. And just from my own clinical experience, I can say that just trying to go through all of these different tests is very challenging. And even in the medical community, it's hard for us to decide which ones people should do because there's pros and cons for all of them. And if physicians and clinicians can't agree on things, it's very hard to imagine that patients could sift through all this information and actually make choices about it. And so what we did was we actually tried to test a few different ways of offering the choice between colonoscopy, which is the most predominant form of testing in this country, and fecal immunochemical testing, which is also a evidence-based approach to cancer screening. It's very different in terms of characteristics, but we know that a lot of the guidelines suggest offering choice is better. But one of our hypotheses was to see if increasing choice or offering the choice between those two could substantially increase participation, and also how you offer choice between colonoscopy and FIT. Could that alter whether people choose to do one test or the other? And this really is informed by a lot of principles that we know from behavioral science. So the behavioral scientists have been looking at things like how you make purchases online and how you think about investing in retirement. And we're just starting to think about applying these same principles, ways that we know that humans are predictably irrational. We don't necessarily follow textbooks when it comes to making decisions. We all make mistakes and sort of have these sort of systematic biases when we make decisions. And so we wanted to look at how you offer these choices between the different tests.
Yeah, so interesting. So it looks like you had about 440 patients. They were from 2 different practices from Penn. I liked how you included it was patients who had 2 primary care visits in the last year, so they were patients who were plugged in, but were still overdue on their testing, which seems like a pretty reasonable population. It's not the hard to reach patients who aren't getting any care. Nice. And then what were the 3 arms you did?
So the control arm was just offering colonoscopy alone. And so our health system, like many health systems across the country, use colonoscopy as a preferred approach. And so in that first arm, all we did was send them outreach basically saying that colorectal cancer screening is important. And if they call this specific phone number, they could basically get VIP access to direct scheduling for a colonoscopy. So that was the first arm. The second arm was a sequential choice arm. So in that arm, we sent the first wave of outreach was the same exact thing as the first arm. So we offered them colonoscopy. And then a month after, if they did not participate in colonoscopy or they did not schedule, we actually sent them a FIT kit, which is a fecal immunochemical testing kit. And so this was sort of this sort of sequential choice option. This is something that's actually recommended in some of the guidelines to say that you should offer FIT if people don't agree to colonoscopy. The third arm was something that we called an active choice arm. So in that arm, we sent them the FIT kit, but also gave them the option of colonoscopy. So this is something that a lot of health systems are doing as well. And so then we tried to see what the response rate was between those 3 different arms. And our specific primary outcome was whether they engaged in any form of evidence-based colorectal cancer screening within 4 months after initial outreach.
Right. And it looks like, sadly, there was no statistically significant increase in colorectal cancer screening. It looks like in Figure 2, you can see the results. The point estimates of the screening did nudge up a little bit, but not enough to show a statistically significant difference. Do you think that was a power issue, or do you think there really was just no difference there?
Yeah, so when we powered this study, we actually looked at a couple other studies that we did across the health system, basically offering the same form of outreach. And in those studies, we just offered them FIT testing. So we said we just mailed them a FIT kit. We didn't give them the choice of colonoscopy, and that was because they had been offered colonoscopy a few different times before. And in those ones, we got a response rate at 3 and 6 months of about 29%. So, in going into the study, we felt that it would be powered to detect something like a 10 or 11% point difference, because we thought that would be sort of meaningful from a clinical standpoint. And so while I'm certainly open and I think it's likely that there is some small difference in increase, it wasn't something that's substantial enough to be clinically significant in our minds, because the alternative would be that you could just send them a FIT kit and you can get 29% participation. So that's why that was very surprising to us that we only got about 20% participation when we send them both the FIT kit and the colonoscopy. You would expect from a sort of rational perspective that offering both colonoscopy and FIT should be no worse than just offering FIT alone. Because, if we were all computers and we are all hyper rational, we would, if we felt that FIT was in our interest, we would do FIT. And if we felt the colonoscopy was in our interest, but there's no reason from a, purely sort of traditional conventional forms of thinking that offering colonoscopy and FIT should have decreased participation than just offering FIT alone.
And I was struck in the discussion, one of the thoughts behind maybe why these findings occurred was the idea of choice overload. I really like that term. I think we talked a little bit about that, but I was wondering if you could just kind of go into that thought process a little bit.
Sure. So there was actually a landmark study about 2 decades ago in the social science literature. So it was a topic that was similarly important to colorectal cancer screening. It was how consumers purchase jams at supermarkets. And so what they did was they actually randomized consumers to basically getting 2 different forms of a presentation at a supermarket. So one of them was offering them 6 choices of jams, and the other one was offering 36 choices of jams. So traditionally, we think that more choice is always better, because you always have the option value. If you didn't want rhubarb jam, you could go with strawberry jam, and if you didn't want that, you can go with whatever forms of jam that you want. And what they found was that if you offer them 36 choices, it actually increased the number of people that looked at the aisle and actually were intrigued and walked over. But if you actually look at the percentage of people that actually purchased one of the jams, it was actually lower in the 36 choice versus the 6 choice. And so they actually hypothesized that this was something called choice overload, where people could choose, one or two, one of the jams, or they can choose not to make a decision altogether, because they were sort of overloaded by the sort of cognitive load of that. They also hypothesized that in situations where there's more uncertainty, where there's less information about the different options, and perhaps when people may not be as interested in participating, that those are situations where there might be more choice overload. So, we're sort of concluding that perhaps in a situation where people aren't that excited about participating in colorectal cancer screening, even one additional choice might actually decrease participation.
Yeah, that's really interesting, especially with the sequential choice, where it seems like, oh, it's just one more thing. I meant to do that other thing. I never really got around to it. Maybe I can just do this FIT testing instead. It's less invasive, or at least seems less, less yucky than a colonoscopy for a lot of people, I would guess. But I mean, I totally relate to the jelly, especially. I think one of the most stressful moments I can remember in the last year is trying to get yogurt at the grocery store. And there's just so many different axes to get so many different things. And, I'm biased. I'm an ER doc. I deal with a lot of, I think, traditionally stressful things as part of my daily job that aren't too stressful for us. But yogurt is a tough one. I usually end up messing it up too. But this is just fascinating. I try to work. I don't have the science on it, but I try to work some of this into my practice a little bit. Like when I have patients who need refills of their chronic daily meds, Usually what I'll try to do is just prescribe like 1 week or 2 weeks worth of their like hydrochlorothiazide or something like that, based on the theory that I've totally made up, that if I had a month to get around to following up with my doctor and getting a refill, there's a good chance it'll be on a back burner and I never get to it. But if I only have like a week or two and that deadline's there and salient for me, I may not get it. And I think somewhat with the cancer screening, it's so tough because you basically have to take positive steps to minimize the risk of getting cancer years from now. Our brains are just so bad at that math.
Yeah, absolutely. So we know from the field of behavioral economics that we all engage in something called parabolic discounting, which means that we discount things in the future, but we discount it a lot more than we should. And so cancer screening is a classic example of this, right? So the benefits that you'll have is that you might live a little bit longer, many years down the road, by not getting colon cancer or sort of being treated earlier. But the cost of that is immediate and something that people probably don't want to do. Even stool testing is something that people may not be so excited about doing because it deals with something that they're not particularly interested in thinking about or talking about.
Definitely.
Right.
One other thing that I really liked about how this was sort of set up was the sort of qualitative component that came afterwards, so the post-intervention questionnaire. And I was wondering if you could just tell us a little bit about that and what you found from that.
Yeah, so as with any pilot study or any sort of small study, we want to understand why things may have worked or why things may not have worked. And so what we did is we surveyed a subset of participants in each of the arms, and we tried to get a sense of if, based on what they learned from this, whether they would be they're sort of more interested in colonoscopy or more interested in FIT. And this was after they've sort of been primed. So, for example, the first arm was just offered colonoscopy, never got offered FIT testing, but we still sort of asked them about that. And what we found was sort of similar results in that what you were offered and how you offered it might actually alter your perceptions of those different tests. And that sort of kind of supports, I think, what some of our conclusions are, which was that certainly patient preference has a lot to do with these things, but how we offer preferences to patients can dramatically change their participation. Whether we offer one test first or the other test second, whether we say that one is a preferred test or those are equal tests, all the framing that we offer to patients might actually change their perception of whether they really want to participate in one or the other. And the other thing to note, I think, about the study is that it existed as a pragmatic study in a health system that really offers colonoscopy for the most part. So about 90% of screening at our health system is done by colonoscopy, which is really not that different from most other health systems across the country. And so there's already these sort of biases in place that colonoscopy is the preferred test. And so offering FIT on top of that plays into some of those sort of existing thought processes.
Okay. Well, fascinating stuff. Really great study. Thank you for joining us. Thanks for submitting to JEMA Network Open. Have a good day.
All right. Thank you so much.
Great. So moving on, we've got a few people who have joined us. We've got James Crossan, Ken Cranston, and naloxone addict Ryan Marino, a toxicologist at large, who's joined us. So welcome all.
Hi.
As we're moving into the table of contents rundown. So first up, we've got the association between hormone therapy and muscle mass in postmenopausal women, a systematic review of meta-analysis. These authors found 12 studies, 4,500 patients. There are 22 different hormone therapy arms in their 12 studies. 15 were estrogen and progesterone, 7 were just estrogen, mean follow-up of 2 years. 7 of them showed loss of lean body mass in postmenopausal women, and 14 found a protective effect of the hormone therapy. But the effect was really small. It was between 0.05 and 0.18 kilograms of less lean body mass, which and that wasn't even a real significant difference. So.
Yeah, no, I thought it was really interesting. And they do mention that a lot of these studies that ended up being included, there was a lot of imprecision, a lot of biases, but still interesting and I think pretty pertinent because a lot of people are talking about this issue.
Yep, we've got an aging population. Women live longer than men, so we'll continue to age more than men will. And sarcopenia is certainly a fun word to say, and it seems to portend badness as we get older. There was a stat in there. I think it was 22% of the world's population will be older women in 2050.
Yeah, no, I couldn't believe that.
Women. Yeah, it's fascinating. Yeah. All right, next up, we've got 2 different transplant papers. The first one is association between declined offers of deceased kidney, allograft, and outcomes in kidney transplant candidates. So basically, I don't know a lot about transplant. You might know more than me, or you probably know more than me. But Apparently, the transplant centers turn down a lot of deceased donor kidneys for a lot of different reasons. 9 out of 10 times is because of quality of the organ issues. But they basically looked at 280,000 transplant candidates from the list from UNOS from 2008 to 2015. They were on average on dialysis for about 1.2 years. About a third of them ended up getting a deceased donor kidney. About a tenth of them got a living donor kidney, and then 9.3% ended up dying. And then about 20% were removed from the wait list at some point without any of those outcomes. On average, there were 10 kidney offers a day nationwide, but there were some differences in those who got the kidneys and didn't. And basically, of people who got a deceased donor kidney, it took 17 offers over an average of 422 days to get a kidney transplant.
I know, I couldn't believe that.
Yeah.
That was pretty crazy. And I was also really struck by the fact that many of these kidneys were eventually transplanted.
Yeah.
And I think the author suggests this too, that there's sort of varying levels of acceptability of kidneys between centers. And the other thing that I thought was sort of interesting is they also talked about geographic heterogeneity in the odds ratios of death while remaining on the wait list.
Right.
So definitely a lot of variation.
Yeah, it was really interesting. I mean, for me, when I first started reading this, not knowing a lot about it, it seemed like, wait a minute, all these kidneys are going to decline. It was like, all right, most of it's for quality concerns. There's a very small percentages for patient factors or logistical factors, but it was actually kind of reassuring. But apparently 84% of deceased donor kidneys are declined at some point before they eventually get transplanted.
Yeah.
Which is a lot.
Yes.
Yeah, it's interesting stuff. All right, next up, we've got a liver transplant patient. You want to cover this one?
Yeah, sure. So comparison of liver transplant waitlist outcomes among patients with hepatocellular carcinoma with public versus private medical insurance. So this was a single-center cohort study. It looked at 705 adult patients with hepatocellular carcinoma. And between, I think it was 2010 and 2016, and they were trying to look at liver transplant waitlist outcomes depending on what type of insurance you had. And so they looked at patients that had, this was in the Kaiser system, so they looked at patients that had Kaiser Permanente insurance, other types of private medical insurance, or public medical insurance. And one of the outcomes which I thought was interesting is they were looking actually at dropout rates from waitlist, either due to liver death, either due to death due to liver disease or progression of HCC. And so they found that the cumulative incidence of people that ended up being transplanted in this cohort, so 67% of those had the Kaiser Permanente insurance versus 64% having other private insurance versus 48% having public insurance. And they found that almost 25% of those who were dropped from the liver transplant waiting list due to tumor progression or death were, I believe that was in the Actually, I'm sorry, that was 19% that dropped out from the public insurance, yeah. And the other thing that was sort of interesting is that they looked into some of the reasons behind why that dropout occurred, and they found that things like poor social support, loss of follow-up among the publicly insured folks were big issues.
Yeah, and they didn't have the power or qualitative capacity to go into all the reasons why there were differences, but they could certainly look at some of them. And social support and loss of follow-up were certainly the biggest differences that they could find. Some of the things they hypothesized about were that in general they found that the patients with Medicaid had more progressive disease at baseline, although they found that when you look at other studies, it looks like even when they have the same level of baseline disease, there's worse outcomes and less likely to get transplant. But also less education, more comorbidities, fewer social support, less subspecialty care access in Medicaid. So all sorts of reasons why there's health disparities, which is unfortunate.
Yeah, definitely.
Yeah. All right, moving on to another slightly probably equally pessimistic paper, unfortunately. Oh, we've got another person joining, Amir Ali Surapur. Apologies for my poor pronunciation. But this is another interesting one looking at primary clinic appointment times with practice habits. So this one looks at opioid prescribing. It's from the same group. We've talked to the authors before about, I think they did colorectal screening. And initially we had talked about a paper where they had done, what was that one about? Vaccines, flu vaccines, and time of day of appointments. And that actually had to come out of their data. They hadn't even been looking to get that. But basically found that as you go throughout the day, primary care docs in their study were more likely to prescribe opioids for new painful conditions. Also patients who were late to their appointments, or if they were running behind in the clinic, the later they were, the more likely they were to prescribe opioids. Some of that, I think the gut instinct, which this paper can't figure out, is that as you're more behind, as you're busier, it's just easier to cut the corner and say, all right, you've got a new painful condition, here's your pain meds.
Yeah.
And one of the things that supports that that's what was going on was that there was not an increase in NSAIDs or physical therapy referrals, which are basically, the same amount of ease of doing.
Yeah, I thought that was really interesting when they looked at that, because I would think that, well, there are different options for pain, but it's sort of interesting that the opioids were the only ones that sort of showed that difference.
Yeah, but as a prescriber, I'll say sometimes it's do I have the emotional energy to how much am I going to be able to put into this encounter? And the later in the day, the more you're worn down, the more you're running behind already. It's certainly plausible that that's a reason.
Yeah, definitely. I have to say too, I think at one point they talked about the number of appointments or the number of people that were being seen. I couldn't believe it. I mean, it was like 20 people.
Yeah, they looked up the 21. They classified it into 21 appointments.
Yeah, so just coming from an academic perspective, it's a little different, I think.
Yeah, I don't know. I mean, I primarily work in an academic center and mostly supervising PAs and residents, so it's not uncommon for me to see 20 patients in a shift.
Sure.
That's actually on the lower side, but that's certainly very different. And again, I've got minions doing most of the grunt work for me. One thing that was really nice here is they were using a big data set from Athena Health, and they had 680,000 appointments for 640,000 patients among 5,600 primary care docs in 2017, and there's only a 4.7% rate of opioid prescriptions for new painful conditions on patients who hadn't been taking opioids before. So that's actually like less than 1 in 20 seems actually pretty reasonable.
Definitely.
So that's there's lots of bad news about opioids, and including some in this paper, but that's pretty reasonable. But yeah, I could certainly understand, again, getting into behavioral economics. The more emotion, I've only got so many good decisions, only so much emotional energy, only so much I can put on a brave face and talk to a patient. On the flip side, I'm still an optimist, and I am totally impressed by how much I think I overestimate. Patients are here just for a prescription, and if you explain what's going on, how the patient's going to do, show concern, say what works really well for this is prescription strength ibuprofen, or help patients deal with it. I have many fewer arguments or much fewer resistance to non-opioid plans than I think a lot of cynics would argue or predict.
It's good.
Yeah, it's good. All right, so moving on to the next paper. This is an interesting one from the University of Michigan. It's a qualitative study among 26 current and former surgical faculty with a band of between 4 and 7 years of employment at the University of Michigan from 2000 to 2017, overall 3 to 22 years of total faculty experience, and talked about what were the barriers and facilitators to women advancement in the Department of Surgery there. So obviously it's a qualitative study, it's a small sample, and it's mostly based on their local experience, but there's some really interesting stuff that they found, and basically they broke it up into a couple different themes that they were able to identify, and things that seemed to be really helpful. There were good things like women in leadership or leadership opportunities, or just an intentional focus on inclusion were all things that were helpful.
Yeah, I know. This was really interesting, I think, and I think it had piggybacked off of some prior work that had been done looking at women in the system and finding that they were less likely to advance from associate professor to assistant professor. Some of the themes that came up really resonated with me, and I there was a quote actually that they talk about in the paper that I just wanted to mention. It's not anything big that undermines women in academics. It's many, many, many small inequities that build up over a career. I thought that was very poignant. Yep,
absolutely. Obviously, this isn't something that I deal with a lot in my work. Neither a woman nor a surgeon. And again, I think one of the positive things here I found is that one of the big barriers they found was lack of proper mentorship, and one of the big facilitators was mentorship and sponsorship, and that's something that's actionable and something that leadership who's bought in can do things about. So it's not all just insurmountable discrepancies that we won't be able to solve.
Yeah, definitely.
So, obviously, lots of problems to solve, and there's still a ton of inequities. And one of the things they mentioned was that there were salary inequities, and that women were, there was at least a report that women were getting paid less.
So again, actionable item, potentially.
Yep, absolutely. Stuff that we can do about. So again, I'm an optimist. There are problems we can solve. Lots of opportunities for improvement. All right, next up, this paper is again out of my wheelhouse, but there's some brief things we can talk about. But a bunch of pathologists or pathology dermatologists, dermatopathologist.
Yeah,
I don't know how to dermatopathologist makes sense. Did a survey which they found patients on social media to talk about the perspectives of the patients with dermatofibrosarcoma protuberans. And looked into some different factors. They had 214 patients who did an online survey. There was a median delay of 4 years between first noticing their lesion and getting diagnosed, with a range of 1 to 42 years, which is a huge range, which is why we do medians and not means. 45% first found a flat plaque despite it being called protuberans, and only 3/4 of them eventually became protuberant, which is interesting. And a lot of them got various surgical cures, things like Mohs or local or wider excisions. And just want to give a shout out. The senior author is Gerard Gardner at JM Gardner MD, who's on Twitter and is I don't know. I'm always impressed by what kind of, I don't know, as someone who's not interested in histopathology, how many cool pictures you can put up.
One other thing that I liked about this was I think there are a lot of, sort of more and more we're seeing people leveraging social media to get information about epidemiology and public health, et cetera. But I hadn't thought about it in terms of recruiting patients and family members for rare diseases, which I think makes a lot of sense. It's just another tool in the toolkit to use to get answers.
Yeah, and one of the things that's positive about that, or that I'm optimistic about, is a lot of very rare diseases. Traditionally, it's been hard to get communities of patients together, and there's a lot of online communities where patients are able to network with each other. And from the research side, if you can find one person or one small foot in the door, that can often give you access to a huge sampling of patients for rare diseases, and help us figure out more to ultimately help the patients, which is great.
Yeah,
that's fun stuff. All right, this last one is another paper that's out of my wheelhouse, and frankly, I'm a bit confused by. But they looked at all of the people in Alberta from 2003 to 2017, and basically whittled it down to people with chronic inflammation, or excuse me, with severe obesity, so BMI over 35 or 40, and tried to look at the association with things like chronic inflammation, insulin resistance, and severe obesity, and how that impacted mortality, myocardial infarction, cancer, and chronic pulmonary disease, and found a bunch of different relationships that went with signals in a bunch of different directions, which makes me think there may not be ultimate signals about inflammation meaning one thing or another.
Yeah, I know. I find inflammation in general is sort of confusing because there are so many things that can be associated with it, particularly the markers that we have for it, right? They're not always very specific. So I think confusing. But, they had 400,000 participants, which was pretty amazing, I thought. And there were a lot of interesting things in there about looking at, women versus men and sort of what inflammation and sort of the presence of obesity and adverse outcomes means for both of those groups. And they were different.
Yeah. And it's interesting just how different the different signals were. So just a few examples. Women with chronic inflammation, severe obesity meant lower mortality risk overall, but no difference in men. Severe obesity had higher mortality risk in men without inflammation. For MI, severe obesity was associated with increased risk in both men and women with inflammation, but not in women and men. Or sorry, without inflammation, but not in women and men with inflammation, and it keeps going.
Yeah.
And it was hard for me to read and even sort out into some notes. So I'm not going to say any more about that.
But very interesting. Yeah.
Yeah, so it's interesting stuff, and again, this is just one more little piece of a bigger puzzle where people are doing lots of research on. And it's also always interesting for me for things like this. We don't have gold standards for what inflammation means. They're basically using CRP levels.
Yeah. Exactly.
So again, what tip of what iceberg does that actually mean?
Yeah. TBD.
Yep, absolutely. Great. Well, thank you for joining us today. You can get these papers and more at JAMAnetworkopen.com. We'll be on again next week, probably again Tuesday at 3 p.m. Central Time. We have 2 new releases coming out next week, Wednesday and Friday morning at 10 a.m. Central, with our new papers coming out. Everything's free and open access online. Of course, follow us on Twitter, Facebook, Pinterest, LinkedIn at JAMA Network Open.
Thanks so much.
Yeah. Take care.
Bye.